Jess. I'm a dietetic intern from Sodexo, and the topic that I'm going to be presenting today is pregnancy outcomes in patients that have cystic fibrosis. So some of you might be wondering why I chose this topic, and growing up, I had two next-door neighbors who were twins who both had cystic fibrosis, and at a young age, I really never understood this disease. I constantly saw them taking enzymes with everything that they ate. They were putting salt on almost all their foods. They were receiving physical therapy at their house with different nebulizers and treatment, and I never really understood any of this. And today, these girls are both 26 years old. They're at reproductive age, and I recently read an article in the Journal of the Academy of Nutrition and Dietetics on successful pregnancy outcomes in women with CF, so I thought this would be a great topic to research more information on and see if there were research that has been done. So that being said, the agenda that I'm going to be going over is background information on CF, how it affects the body, different treatments, nutrition in general with CF patients, and then some considerations for pregnant women with CF, the life expectancy of a CF patient, and then just comparing some past research versus present research. So the three main objectives, I'm going to review background information, I'm going to review the importance of good nutrition status and its association with lung function and longevity and the role that it plays for successful pregnancies, and then just compare two research studies. One was a case series and the other was a retrospective chart review. So I just wanted to start off and see what we already know about cystic fibrosis and do a quick icebreaker. So I passed out two index cards, pink and a yellow. So I'm going to read through a couple of statements about cystic fibrosis just to see what we already know. So if you could hold up the pink card if you think it's false and the yellow card if you think it is true. So the first statement, CF is the most common autorecessive life-threatening disease today in the United States.
Most common autosomal?
Okay, good job, it's true. The second question, enzyme replacement therapy helps prevent maldigestion and malabsorption. All right, great. Number 3, before pregnancy, a BMI greater than 22 is recommended for patients who have CF.
Never guess.
All right, good job. And the last question, the current life expectancy of individuals with CF is less than 20 years old. Okay. All right, so the answer is actually false. As of 2009, the CF Foundation concluded that the life expectancy is actually 38.3 years old. So transitioning into what is CF in general, it's, like I said before, the most common autorecessive life-threatening disease in the United States. It is caused by a defect on chromosome 7. So chromosome 7 in your body is the area where the CFTR, it's the CF transmembrane protein regulator. This is responsible for coding in your body. So this protein controls the movement of ions and water throughout the body. So when there's a defect on the chromosome, the ions and the water are not distributed properly throughout the body. So this can cause, the abnormal transport of this can cause a thick and sticky mucus to be produced. So typically this mucus in our bodies is a thin layer of mucus, and when the transmembrane and the defect of the chromosome makes this thick mucus, it can block different tubes and ducts in the body, leading to these mucus secretions. So the number one cause of leading deaths in patients with CF is because of pulmonary infections that these secretions can cause. And blockage can cause different damage to organs, such as the respiratory, GI, endocrine, and reproductive systems. So treatment over the years for CF has significantly improved, but it does There is different oral and inhaled medications that are prescribed that reduce inflammation, as well as chest physical therapy and airway clearance techniques to release some of the thick secretions that are trapped in organs, especially in the lungs, as well as enzyme replacement therapy. So patients with CF are required to take enzymes anytime they eat a meal or a snack that has protein or fat to help break down the food and prevent maldigestion and malabsorption. And also, following a specific diet is extremely important. So nutrition in general with CF patients, good nutrition is associated with better lung function and survival. So it is really important for RDs to provide guidance and counseling to patients so that they can achieve optimal growth and that they can have potential to maintain an adequate weight throughout their life. So just a little bit of considerations for pregnant women who have cystic fibrosis. Their energy needs are 110 to 200% greater than the recommended caloric intake for healthy individuals of that same age and sex. So this number can be extremely difficult to achieve. It's because of their inflammation in their body, their energy costs for their constant cough, and the malabsorption. So I just put an example here. If the DRI for, say, a 26-year-old healthy female who's pregnant is 2,354 calories, and she needs 200% greater, she's going to need almost 4,700 calories per day. So as RDs, this can be really hard, and we have to work with the patients to recommend that they consume high-calorie meals, snacks in between their meals, such as supplements, smoothies, homemade milkshakes that are high in calories. In recent findings, it's actually been stated that weight status is now the #1 contributing factor to a successful pregnancy for CF patients. It used to be about their pancreatic function, so if they were pancreatic insufficient, it was documented that they really couldn't have a successful pregnancy. It was just stated that patients that were pancreatic sufficient were able to have successful pregnancies. So now with this new look at weight status, it's really recommended that the BMI is greater than 22 before they become pregnant. So working with RDs and nutritionists is extremely important. We want to make sure that they maintain their adequate weight so that they're able to deliver their baby to term. The malabsorption of fat is also another important factor for CF patients. About 80 to 90% of the fat is absorbed in CF patients, whereas a healthy individual will absorb 95% of fat. So it's important that they have increased fat in their diet, increased fat-soluble vitamins, as well as increased protein to preserve their lean body mass. So the fat recommendations are 35 to 40% of their total calories, and protein needs are 1.5 to 2 times the DRI for their age. Also, women have less than optimal pre-pregnancy weight. They may consider oral supplements or even short-term nutrition support before conception, but they need to realize that after pregnancy there could be future complications with their nutrition status. Furthermore, sodium intake, due to that inadequate transport of the ions in the water, like I was talking about at the beginning, can cause a loss of sodium chloride through increased salt content that comes out in the sweat, saliva, and tears of CF patients. So they really need liberal amounts of salt in their diet, especially in hot weather and during physical activity. And to date, there have been really no published research studies that have focused on micronutrients such as folic acid and vitamin D, other minerals, specifically for women who are pregnant who have CF. So as stated in the consensus article that I looked at from the Journal of the Academy of Nutrition and Dietetics, it's recommended that right now we need to make the same recommendations for patients who do not have CF who are pregnant for certain micronutrients like that. And then talking about life expectancy, back in the 1930s, 1930s, CF patients were not living to greater than 5 years of age. And with improvements in overall treatment and the emphasis on proper nutrition, this has significantly increased, and patients are living to 38.3 years, which was stated by the CF Foundation in 2009. So there are about 1 in 3,500 live births that have CF in our country, so around 30,000 Americans have this disease. And what's really shocking is that over 50% of them are above the age of 18. So that being said, they're reaching reproductive age and wishing to conceive now. So I tried to look at some past research versus present research for the purpose of this presentation. And in my findings, there are a lot of retrospective chart reviews and case reports and international studies, but since the life expectancy of CF patients is new and upcoming, that there hasn't really been a lot of longitudinal studies that have taken place with big subject groups. So there's really little evidence about management techniques for nutrition management for women who have CF and who are pregnant. So it's important for RDs to consider recommendations for pregnant women without CF and use clinical judgment to meet their needs. So we should still perform nutrition assessments based on their past medical history, look if they have any deficiencies in certain vitamins and minerals, and make recommendations from there. Certain nutrition diagnosis statements that could be used are inadequate energy intake, increased energy expenditure, inadequate oral food and beverage intake, and increased nutrient needs. Two recent studies that I found that literature was showing that the survival for women who had CF who became pregnant and gave birth may not be worse for women who have CF who do not become pregnant. So I'm going to review two international studies that I compared for this presentation that really look at lung function and BMI in regards to having successful pregnancy outcomes. So one was a case series, and the other was a retrospective chart review. They're both pretty similar, but they went back over time and looked at assessments that were done at the hospitals and took different variables and baseline demographics and compared them to see if there was a correlation. So the first study was from the European Journal of Obstetrics and Gynecology and Reproductive Biology. The purpose of this study was to assess maternal and fetal outcomes in women with varied pre-pregnancy lung function, and they wanted to determine if it would be recommended to carry out a successful pregnancy. So there were only 12 women who were in this study, and there were 15 pregnancies, so a few women had more than one pregnancy. And it took place in the United Kingdom between January 2003 to 2011. It was a small case series. The information was reviewed and collected over an 8-year time frame. And in this study, there was past research that concluded that having an FEV1, I don't know if anyone's familiar with that, but it stands for the forced expiratory volume, and it's a measure of it's a measure of 1 minute measured by spirometry, which is one of the most common pulmonary lung function tests. So both studies have really looked at this lab to see if that had a correlation, their pulmonary function versus fetal outcomes. So in past studies, it was saying that if they had an FEV1 less than 50 to 60%, the woman should avoid pregnancy. So this study really wanted to take their own data and see if that was true. So this was just some baseline demographic differences. There were 15 pregnancies from 12 women. Their mean age was 28. They had a baseline FEV1 of 63.6, so it was around that number that they predicted. And they had a mean BMI of 21.4. A couple of them had other comorbidities. And this is just some more postnatal after birth. They took different FEV1 values 6 months after the pregnancy. They looked at average birth weight, preterm weight, and then they based it on a correlation of their p-value. 38 weeks. They really stressed that there was a great multidisciplinary approach throughout the pregnancy. They had a lot of help. There was minimal deterioration in respiratory function that was noted at the beginning versus the 6 months. So overall, in this study, there was no correlation between the maternal lung function, the FEV1 lab value, and premature birth rates because the p-value was greater than 0.05. The second study I looked at, however, was pretty much the opposite results. This study was from the Australian New Zealand Journal of Obstetrics and Gynecology. The purpose was to examine more recent experiences with CF and to provide evidence that may assist a clinician counseling patients about their reproductive decision making. So they really looked at fetal outcomes, maternal survival, and the influence of pre-pregnancy parameters on their outcomes. So there were a couple more women in this study, still a pretty small sample size. There was 18 of them. 2 had 2 pregnancies, so there were 20 pregnancies. It was over approximately a 15-year time frame, and this was the one that was the retrospective chart review. So here's the baseline demographics for this study. There were 20 pregnancies and 18 women. The average age of the woman was 29, and the baseline FEV1, again, was pretty low. It was 65.6. And in general, a normal FEV1 is 100%. So anything less than that can really contribute to showing that there's low pulmonary function. And they did have a few more comorbidities, such as CF-related diabetes. And so this study did show, the 2 highlighted in red here, the variables of BMI and baseline FEV1 showed a correlation between fetal complications. This N equals 8 up here, fetal complications. There were 8 complications that happened in this study. And then the column next to it, there was 12 that did not have fetal complications. So what they were really showing here, the p-value was less than 0.05, showing a positive correlation between these 2 variables. So the women in this study did not all have successful pregnancies. The mean gestation was 37 weeks, and the FEV1 and BMI both showed a significant correlation because the p-value was less than 0.05. One maternal death occurred during the pregnancy. She suffered from severe pulmonary exacerbation, which led to respiratory failure. And this woman, before she became pregnant, had a BMI of 18.4, which was extremely low. She was encouraged not to become pregnant. She had poor pulmonary function. There were also 2 other women who underwent lung transplantation 2.5 to 8 years after the pregnancy. And what that concluded, though, that the women who died and that required lung transplantation all had pre-pregnancy FEV1 lower than 60%. Those that had a higher, greater than 60%, are still living today. Similarly, pre-pregnancy BMI less than 20 compared to BMI greater than 20 was associated with increased rate in adverse fetal outcomes. So some other conclusions that I made from this study, that based on the pulmonary function showing that there were fetal complications, is that RDs may want to look at MNT for improving pulmonary function with patients that have CF. So certain things that we could consider to recommend is in consuming small nutrient-dense meals to avoid becoming breathless while eating while sitting up to ease lung pressure, consuming foods that are easier to chew, that will take less energy to eat, and certain liquids and supplements which offer a lot of energy and nutrients, and they're easier to eat. So for some future research opportunities, both of these studies that I found were international articles, so they were not in this country. There was no control group to compare the results to. A lot of cohort studies that were not available for this topic sometimes have better results because they look at a large group and then they compare to a group of maybe pregnant women who did not have CF. So future research should really consider a larger study size in some of these variables. longevity of CF patients is increasing. And RDs are critical members of the CF team and at all stages of life, especially during pregnancy, to maintain their sufficient weight. And we can only remain optimistic that women with CF will continue to have successful pregnancies in the future. And then this is just some of the references that I used for my research. And if anyone has any questions or comments, I'd really appreciate anything you have to say about this topic. Anyone have any questions? And I have a short true and false post quiz that I'd like you guys to fill out if you could for me. Or if you have a question.
Yeah, what supplement do they have to take with their meals? Is it pancreas?
The enzymes.
Yeah, the enzyme, I'm sorry.
They have amylase, protease, and lipase in the enzymes. It's an enzyme that they should take with all foods and snacks.
Is that one enzyme altogether?
Yeah, I believe it's well, maybe depending. I'm not really sure if they need one or two,
All right,
but
because I saw something about pancreatic deficiencies, or in your presentation, so I don't know whether they're deficient in the.
well, basically, if they're pancreatic insufficient,
yeah.
then they can't really digest
The
anything
fats,
properly.
yeah,
So they
yeah.
need to take enzymes to help them break
Yeah.
down and digest
Okay, so
without
it's not
malabsorption.
necessarily pancreas that they take. It's
Um,
a different.
I have, let
enzyme.
me see, I have it written down. I know it's in my research. Yeah, they're lipase, amylase, and protease, which are all included inside the enzyme to help
Okay.
prevent maldigestion and malabsorption. So with any protein or fat that they take, either snack, any meal, anything, they want to take an enzyme to help them
Mhm.
digest properly.
Yeah. Okay, thanks.
You're welcome. Does anyone else have any questions?
Did they, in any of your research, did they talk about what's the likelihood of their children having CF? If these moms with CF are now having children, are they passing it on?
Yeah, well, I didn't really look into that too much in the studies that I have, but the autosomal recessive, that means that an individual must inherit two of the copies. So it must come from one from each parent of the defective gene. So a parent may carry the defective gene, but it has to come
Right.
from